Good afternoon, everyone. Welcome to this is part of our new webinar series that we are very excited to share with you all here at Review Healthcare. Today, we are going to be talking about split shared visits. So I hope you have, it should be lunchtime for those of you on the East Coast, Central Time, not quite, you're almost there, but if you have your lunch, pull up a seat as we're going to be discussing soon some of the new updates related to split shared billing guidelines from Medicare. So, do me a favor before we get started. One of the things that I ask is that you share this with as many people as you possibly can. Share it on LinkedIn, share it on Instagram, share it on all of the places that you think everyone could benefit from this great information. So, again, my name is Leslie Bowles. I am the president and co-owner of Review Healthcare, and I'm happy to be presenting on split shared guidelines with you all today. So we're just going to dive right into what we're going to be talking about because I think this is valuable information. Split shared E&M and incident 2, right? Although we're not talking about incident 2 today, are two of those guidelines that no matter how many times you've heard it, you've read about it, it's really good to go through a refresher. So that's why we found it really important, especially coming off the heels of the pandemic and all of the different guidelines and policies that were changed during that time, for us to discuss it with you all today. So what you should know about split shared E&M visits: there was a Medicare Matters Learning MLN Matters article that came out, and the effective date was January 1, 2024. Implementation date was recent, August 1st, 2024. And what we're going to be speaking from or referencing is the information from that article today. So we're going to have that. We're actually going to share and disseminate that information along with these slides today for all of you that have joined us, so that you can reference that information too. But everything we're going to be discussing today is from that most recent article. Okay, so I want to start off by saying that. So let me just move to the next slide, just to give you a little background more. So these split shared new updates are from Medicare Claims Processing Manual. There you see the section along with the change request. It aligns with the 2024 payment policies under the physician fee schedule. So that new payment policy that came about for 2024 also reiterates a lot of the information that we're going to be talking about today. And I think this is really important, right? When we receive information like this, new information, it's always good to know who does it affect. So it affects physicians, non-physician practitioners, NPPs. So when we say NPPs, we're referring to individuals like APRNs, nurse practitioners, and physician assistants, right? There may be other types of NPPs that fall under that category for your local Medicare administrative contractor. It's always important, no matter what part of the country you're in, whoever's listening to me today, it's always important to consult with your local MAC. Remember, your MACs are those individuals, or those agencies rather, that represent Medicare in your region. So every region of the U.S. is sectioned out by different Medicare administrative contractors that have been contracted by Medicare directly to go out and implement their rules and their policies, such as this one. So keep in mind, with that being said, there's often more restrictions or restrictive measures that one should look into for their local MAC. So I always say, just from a federal perspective, we know who Medicare, federally, how Medicare defines NPPs, but you want to make sure you understand that across the board when it comes to your local MAC. And then other providers billing Medicare administrative contractors. All right, so first and foremost, let's talk about the definition of split or shared visit. So the definition is an E&M visit that is performed by both a physician and an NPP in the same group. So let's concentrate on that for a second, right? in the same group, meaning employed under the same practice, facility, hospital, within the same tax ID number. This is extremely important to remember. So when we're talking about a physician and an NPP, a non-physician provider, sharing a visit or an E&M visit, in this case, we're talking about two individuals that are from the same group. It occurs in a facility setting, and either practitioner can bill if they provide the service independently. That's important to remember, right? So if a split shared, as we move along, we talk more about the split shared component. If that does not occur, then either practitioner can bill if they provided that service independently. So whoever provided that independently, let's just say the intention was to perform it, split or share the visit, and it didn't occur, whoever performed that service independently is who that service is billed out under. Payment goes to the practitioner who performs the substantive portion. This is really important, and we're going to talk about the definition of substantive, because I think there's a lot of confusion around that currently, and we want to clear that up today. So I'll give you sort of a case scenario, because I realized as we're going along the slides, we don't necessarily have that as an example. So if I, Leslie Bowles, am the doctor, I'm playing one here for you all today, and then Markia, who's assisting with moderating in the Q&A in the chat, thank you so much, is the APRN. If her and I participate or share in the same E&M visit, we go to see Mrs. Brown in Hospital C, right? For that inpatient E&M visit code that we bill for, if we both split or share and contribute to that complete visit, that is the definition of split shared. When physician NPP, we work in the same group, same tax ID number, all of that good stuff. Okay, so I hope that's pretty clear there. Let's move on to the next slide. So facility setting, let's talk about where it's prohibited, right? Where you could not bill for split shared E&M services. So institutional setting, where payment for services and supplies provided incident to a physician or NPP's professional services is prohibited. So what this means is, so for those of you that do know Incident 2 rules and guidelines, we know that Incident 2 is allowable in place of Service 11, right, which is for the office setting. So split shared would not be appropriate. Here you'll see there, because that is where Incident 2 is considered allowable, so therefore split shared is prohibited. So it's really important to know place of Service 11, the office setting, where Incident 2 is allowed is where split shared is prohibited. Okay, so I want you to keep that in your mind. In my many years, I've seen a lot of confusion where we're seeing split shared or shared visits on the office outpatient side, place of service 11, where they're performing outpatient visits or in a physician's office, and they're seeing patients there. Split shared is not considered appropriate in that setting. So I just want you to keep that in mind. Okay, so we're getting to the good stuff. We're going to give you the definition of substantive portion. I'm struggling with that word. I apologize. And so the way it's described from January 1, 2024 is more than half of the time spent by the physician and NPP performing the visit, or a substantive part of the medical decision-making per CPT E&M guideline. So let's break that out for just a second. We all know, or you should know, if you are coding, if you are coder, compliance, revenue cycle, billing professional, operations, there was a shift in the way in which we calculated E&M codes from the previous 1995 or 1997 guidelines. So now we have a new method for how we determine medical decision-making, that aspect of an E&M code. We use that sole component to calculate an E&M code, or we have time. So what it's saying here is that the substantive portion is defined by the individual during that split shared visit who performs, either from a time perspective, more than half of the total time spent by the physician and NPP performing the visit. So this is interesting because a lot of people always ask the question, well, I mean, how will I know that? Right? Well, here's the thing. This is where documentation comes into play. If it is not documented, if that information is not documented in that manner, it may be challenging to determine it from a time perspective. So this is very key, right? Same thing when it comes to medical decision making. And we're going to highlight this again during the course of this presentation, but it is extremely important for those of you that are educating your practitioners, your physicians on split shared, that you speak to how important documentation is when we're talking about determining who did what. Okay. I know that there are many different types of functionalities within EMRs nowadays that sort of allows or eases this burden, so to speak. Some people call it a burden, but I call it a requirement, right? When it comes to documentation, it's an essential part of helping anyone outside from a reimbursement standpoint, just from a documentation and just an overall medical necessity, medical clarity of what transpired, clarity of what transpired during that visit. It's extremely important to document what happened. Okay, so this is how we define the substantive portion of determining who did more than the other to decide who do we bill it out under. Now, I don't believe we have a slide on this, but keep in mind, right, that from a billing perspective for a split shared E&M visit, so if the physician performed the substantive portion of the visit, either by time or by medical decision making, and the documentation is clear, then that means we would bill the service under the physician. But let's just say we have involvement by APRN and the physician, and the APRN actually was the one, by way of documentation, that performed the substantive portion of the visit. Then it's billed out under the APRN. Okay. There is, and I'm only speaking to my audit brain, right? This is just, you can call it skeptical. I have seen over the years that a lot of individuals will make the assumption that if I see in the documentation both the doctor and the APRN, we're not determining who performed the substantive portion. We are solely going with the physician. We're making that assumption. I will tell you, based off of these new updates and rules, and definitely from an audit perspective, do not make that assumption, okay? Documentation has to be your guide in determining let's put it this way, which provider, physician or APRN, physician or PA, physician or NP, whoever the NPP was that was involved, who actually performed the substantive portion. This is extremely, extremely important. And Medicare is giving us the definition of how you determine that. Okay, so let's move on to slide 8. So just some other sort of continuing on. For other outpatient, we're going to break it down by E&M code family. For other outpatient, more than half of total time or a substantive part of the MDM is considered appropriate. Inpatient observation, hospital, or SNF codes, more than half of total time or a substantive part of the MDM. Then emergency department, more than half of total time or a substantive part of the MDM. And critical care, they're very specific here, more than half of total time. So this is great. I like this slide because what it essentially is creating for you is a mini audit tool, right? It helps you to audit by, and when we say family, meaning the type of E&M code in which this split share type of billing is considered allowable, it gives you sort of the determining factor that would lead you to decide, okay, who does this need to be billed out under? This is a really, really important part. And I will just say, I know I'm going to sound like a broken record by the time this is all said and done, but I will say this is the most important part from an educational standpoint outside of medical necessity. Let me lead with medical necessity first. But from an educational standpoint and an audit perspective, this is what you're looking for. Who, whether it's medical decision-making or time, right? They can choose. The only one where they don't have that choice is critical care. Critical care codes are all time-based codes. but for the most part, they have the option, medical decision making or time. And so using that and then leading into who performed the substantive portion is how you determine split shared billing. All right. So just some important notes here to think about. Office visits and nursing facility visits aren't billable as split or shared services. This is important, okay? Office visits and nursing facility visits aren't billable as split or shared services. When we are talking about prolonged visits, so for those of you, just a mini refresher on prolonged visits, and these codes, description, and criteria has evolved over the last, I would say 2 years, right? Since the implementation of the 2021 E&M coding guidelines, the new ones, and then the newly updated ones that happened in 2023. They are additional codes that represent additional time beyond the base E&M code service that doesn't fluctuate the level of risk, but it does speak to the additional time spent by the practitioner. So in the case of prolonged visit codes, prolonged visits also fall under the split shared category. So for prolonged visits, substantive portion is more than half of the practitioner's total time and only bill when time is used to select the visit level. And then the determination of the substantive portion is based on time. So it's really, really important for prolonged visits for you to remember that key point there. From a billing and coding standpoint, it is extremely important for billing staff to, or I don't really like the word staff. We'll use the word team members. I don't know why that word irks me so much, but we'll use the word team members. It is really important for billing and coding team members to remember a couple of things. First and foremost, when we're talking about this type of complexity of billing, right? This is the type of billing and coding that requires you to open the record. Okay, so some of you are probably saying to me, well, Leslie, why are you saying that? I don't know a person in this world that wouldn't open the record when they're coding or billing for a particular service. Well, unfortunately, I have ran into some that do not, right? This is really important. We should be doing this every single time. Might add for coding and billing. But as it relates to what we're talking about today, this is extremely important. You cannot determine the substantive portion for time or medical decision-making without looking at the record, right? If you are determining it, it's non-compliant at that point, first and foremost, and it is assumption-based. So it's extremely, extremely important for your billing and coding team members to understand the definition, how to bill appropriately, and how to identify the practitioner or the physician who performed the substantive portion for that visit. That's extremely important. I believe in holding what we like to call, we call them office hours. Some people call them Q&A sessions, but it's really important because sometimes these really complex guidelines do require refreshers. So if you are billing for split shared in your organization, your coding and billing team members should be getting together periodically. To your organization could be once a quarter. Maybe for someone else, it's every other month. But it's a really good way of going back and ensuring that everyone understands, asking questions. Hey, this is a unique scenario. Let's discuss it. Hey, we probably need to review this, or we may need to audit this provider for the way in which they're billing for split shared. So it's really good to have these good discussions around it because you don't want to be non-compliant with these rules at all. You want to have compliant coding and billing so that the reimbursement you receive, you can actually keep. And although audits will always come around and audits will always be a part of the equation, right? You want to ensure that you have everything in place to pass the audit. So really important part there as well. All right, so as I'm wrapping up, I know this was only supposed to be 30 minutes. I'll leave a little time at the end for questions. When we talk about medical decision-making, when medical decision-making is used as a substantive portion, each practitioner can perform certain aspects of medical decision-making. So remember, medical decision-making has 3 components. And so the billing practitioner who performed the substantive part of the MDM as per the CPT coding guidelines. This is really important. So we don't have time today to dive into the different components of medical decision making. But what you want to evaluate is who performed what part of the medical decision making, who did the substantive portion, who did more that would speak to who warrants the billing for that particular service. And so, what I strongly encourage you to do is to refresh yourself. For all my coders and those of you that are billing for these type of services, you want to go back to the CPT coding guidelines, look at the three components, and use those three components to evaluate, okay, which aspect did the physician do, which aspect did the APRN do, and who did more of those components to determine if they're using medical decision making, then therefore, who should we bill the service under? Okay, or for rather. All right, so key takeaways. These updates came out in January. Okay, so it's really important. I think it's extremely important when new updates or new guidelines come out that we audit to ensure that we're following them compliantly. Okay, so if you haven't, it's September already. We're almost in October. If you have not looked at your records and you're performing split shared and we have these new guidelines, this is a good time to do a spot check to see if all of the documentation and everything speaks to all of the requirements that Medicare and your local Medicare administrative contractor has in place. And then ensure you know the new definition of substantive portion for timer medical decision making. It's really important to evaluate things like accurate documentation and billing. And again, refer to your Medicare administrative contractor's website. Make sure that although you're listening to this great information from me today, and I'm referencing Medicare federally, their policy from their article that they put out that went into effect in January, implemented in August, you want to go to your local Medicare administrative contractor, whether it's Novitas, Noridian, WPS, whoever your local Medicare administrative contractor, you want to make sure that you know the guidelines and the requirements for split shared as it relates to what is allowable under their policies. All right. Very, very, very good. So I am all done. I'm looking at sorry, you have to forgive me. I'm looking at the Q&A box here just to make sure I'm not missing anything. Does anyone have any questions for us, Markia, or comments? Okay, good. Good. Latoya, thank you so much for your comment. You're absolutely right. We are in agreement. Yes. Markia, do we have any other questions? Oh, we do have a question. So someone said, it feels like the E&M visit guidelines are constantly changing or are always changing. What strategies have you found most helpful for staff training? I will tell you, one of the things that I did as a compliance manager when I was working and we were building out a coding compliance program is we actually had alerts, right, from our local MAC, from Medicare and other consultants and agencies that we considered trustworthy and used primary sources to help us keep abreast of all of it. And I think a lot of people miss out on that opportunity to do so because they're like, oh, I don't want my email flooded with all of this information. But this is how I stay abreast, right? I realize that I'm human and I have 1,000 other things to do during the day. So I need notifications, I need updates, I need reminders. And so finding ways for your local Medicare administrative contractor, Medicare, billing consultants, coding consultants that provide information from primary sources is a good way to keep on top of all of these changes. Because believe it or not, there's ways to do that. The other thing I think people take for granted is LinkedIn. LinkedIn is one big professional network. And so I encourage you to network or link with your fellow colleagues in the field, because lots of times they're putting out great information as it's happening. And oftentimes that's even where I find out about new rules or regulations on LinkedIn. So if you're not on LinkedIn, that's also a great place because you have your colleagues who are in the field just like you, posting information from primary sources. I can't not say that again. The importance of getting information relayed from the right source is important. So that's another really good avenue to help you. Does anybody else have any other questions on this? Okay, perfect. Thank you so much, Markia. I want to thank we finished right on time. I want to thank everyone for joining us today here at Review Healthcare for our mini webinar series. Follow us, stay connected with us so you can learn about our upcoming series. And if you have topics that you want to hear about, send them to us. We're happy to talk about it. We are also looking for some guest speakers. So if you are someone who is well-rounded in coding compliance and billing compliance topics, and you would like to be a guest speaker on our platform, please send us your information. We would love to hear from you. Thank you all so much. Oh, yes, and email contact@reviewhealthcare.com to receive the PDF of the presentation. We will forward it to you. Thank you all so much for your participation, and see you next time.